Welcome, everyone. The International Atomic Energy Agency is pleased to start the new series of free webinars on hot topics from the radiation protection in medical uses of ionizing radiation. My name is Zhenya Vasilyeva. I'm a radiation protection specialist in the radiation protection of patient unit of the IAEA, and I'll be your moderator today. Please note that this seminar is being recorded and the participants will be muted during the broadcast. The recorded webinar will be available for later viewing from the webinar page of the RPOP website. Today's webinar will last 60 minutes, including a specific question and answer period at the end of the program. You may enter questions and comments at any time during the presentation by typing in the Q&A box in the right corner of your screen. Your questions will be not visible to other attendees. Please note that the IAEA is not offering a certification for this webinar. I'm pleased to invite first Dr. Ola Homburg, the head of the Radiation Protection of Patient Unit of the IAEA, for the welcome message.
Thank you, Zhenya. First of all, I would like to welcome all of you to this webinar. Radiation protection in medicine has been recognized as an important area by the International Atomic Energy Agency for many years. A resolution was issued at the IAEA General Conference in 1999, which requested the Secretariat of the IAEA to organize an international conference on the topic. This led to the international conference in Malaga, Spain, which was held 15 years ago and which sparked many more actions in the IAEA over the years. One of these actions was the setting up of a website on radiation protection of patients, or the RPOP website. And this website has been a big success over the years, and the visits to the website keep increasing every year, as well as the social media following. The RPOP website was released in September 2006 and has become a top website in the world in the field of radiation protection of patients and, in fact, on medical radiation protection overall. Today, we will have the first IAEA webinar on radiation protection in medicine, and it's very appropriate that Professor Madan Rehani will be the first speaker. My colleague Zhenya Vasilyeva will introduce Madan formally, but I wanted to mention that Madan is the originator of the RPOP website during his years at the IAEA. The topic today is occupational exposure in medicine, and the number of occupationally exposed persons is much greater in medicine than due to any other source or practice. The exact number of occupationally exposed persons as a result of medical uses globally is not well known, but the UN body called UNSCARE has estimated that there are over 2.5 million monitored workers in medicine, compared to 0.8 million in industry and 0.3 million as a result of military uses. So it is an area of interest to many people in the world. A final remark I have is that these webinars are intended to be informative and topical, but they do not necessarily reflect the view of the IAEA or of the governments of IAEA member states, and as such, they are not an official record. However, we hope that through these webinars we can provide a service to health professionals and to other interested parties by informing you about some of the latest findings on important issues in the medical radiation protection. Many thanks for your attention, and back to Zhenya.
Thank you, Ola. We are going to discuss today whether cataract is a real risk to those working in interventional suites. It's my great pleasure to introduce the speaker today, Professor Madan Rehani. Dr. Rehani is currently a visiting professor at the Harvard Medical School and Massachusetts General Hospital in Boston, and adjunct professor at the Duke University Medical Center in Durham, North Carolina. He was formerly a radiation safety specialist at the IAEA for 11 years, and during his tenure, he initiated studies on surveying eyes of interventional cardiologists and support staff for eye lens opacities. These studies, published in peer-reviewed journals and recommendations from the ICRP and the IAEA, have created momentum in many countries. It's now time to hand over to the speaker. Madam, the floor is yours.
Thank you, Xenia. Thank you, Ola. Thanks to IAEA for organizing this seminar and the seminar series, the webinar series. The first topic has been chosen to be of something which is of contemporary interest, and we need to be aware that there are lots of participants in this webinar. It's a question of whether cataract is real risk to those working in interventional suites. If I give an overview of the situation, it did not seem to be a big issue 2 decades ago. So the question arises, why now? In the presentation today, I am not going to cover the radiation doses in different examinations except peripherally. So there are many studies, and the emphasis is on effect, the radiation effect, and that is the cataract or lens opacities. And we are going to look if there are relevant studies and see if there is clear or ambiguous message coming from these studies. And finally, in a very brief manner, I will be dealing with actions ongoing and needed, and that's why I have put it in a very small font, because that's a small part of what I'm going to cover today. So the major emphasis is on effect, that is the cataract, and to see how clear is the message. If one looks back to situation about 2 decades ago, I had been around at that time. Many of the listeners had been, hopefully, around at that time. If we look back, there was hardly a justification on talking about this topic in 1990s. It was a very little possibility at that time. And when we are talking about those working in interventional suites, I am trying to mention that this pertains to interventional cardiologists, interventional radiologists in various specialties of interventional radiology, neuro or other ones, electrophysiologists, vascular surgeons. So these are the category of specialists who have similar level of radiation exposure in their practice. Then there are others who use fluoroscopy in operation theaters, so may not be called as interventional suites, but they are performing the interventional procedures in those locations, whether urologist, orthopedic surgeon, gastrointestinal endoscopist, and other specialists. Their usage level may be little less, but we will see if how much is the concern which should be directed at them. Then there are other health care workers in interventional suites like nurses, anesthetists, radiographers who need to be included in the discussion. And finally, I'll say that I'm not going to be talking about a topic which is so-called based on the A-bomb survivors, like many of the radiation protection part are, that inferences are based on A-bomb survivors. Here we are going to focus exclusively on our audience, that is the interventionalists. So let's get to the question why cataract was not seen as a high possibility in 1990s. And seeing is believing. About a century ago, there used to be injuries to the hands of the operators of fluoroscopy or X-ray machines. So that became a thing of past, almost something like 1930s. So 1930s to 1980s, X-rays were being used reasonably safely. As a result, the physicians in many practices started using them left and right without really much worry about them. The worry used to be directed on radioisotopes, whereas X-rays started to be used extensively without really much worry. On the physicist's side who deal with radiation doses, from a physicist's point of view, one would see that the threshold dose as provided by ICRP was 5 gray for visual impairment and 0.5 to 2 gray for detectable opacities. So this dose was quite high and as a threshold dose for cataract and other effects to be visible. So based on these two situations, this was not seen as a high possibility in 1990s. So let's see what has changed during these 2 decades. Has the threshold dose been reduced? Have there been published reports of cataract among those working in interventional suites? Have there been controlled studies among those working in interventional suites documenting cataract or lens opacities during the past 2 decades as compared to the non-interventionists? So we need to look at these questions to be able to properly answer the topic which we have chosen today. So let's first look at the question, is cataract a real risk to those working in interventional suites? And for that, one will need to talk about the magnitude of the risk. And then, is there a rare chance or a fair chance for those who are working in day-to-day practice? So what we know today, as in early 2016, from the studies which have been published, is that radiation-induced lens opacities have been demonstrated in 1/3 to half of the operators in interventional suites, primarily among interventional cardiologists. So this is a snapshot of the summary of the results available, which I am projecting right in the beginning, and I'll go through the details of these papers and the findings thereof. While these findings have come from work or survey on the eyes of interventional cardiologists primarily, the workload being similar, this should also apply to interventional radiologists, electrophysiologists, and vascular surgeons who work in similar to the magnitude. And one of the table I picked up from our work in which has been published in CCI, the cardiocatheter and cardiovascular intervention, is the dose-effect relationship. We had data from 67 subjects and we estimated the doses. And as the dose increases, the prevalence was also increasing. That was clearly demonstrated that there is a clear relationship between the dose and the prevalence of lens opacities. Since I have referred to lens opacities quite a few times, rather more than the cataract, I think it is appropriate that we distinguish between the two. Let's get into some basic aspects of understanding of the cataract. I'm sure everyone knows, but it's a reiteration that cataract means clouding or opacification of the natural lens of the eye, and which leads to obstructing the passage of the light. This is how the normal vision looks like, and this is how the vision appears when there is a cataract. Similarly, the normal vision and the vision with cataract. Since this is not an issue of only radiation, there are quite a lot of other factors which can lead to cataract. Age, of course, is one, corticosteroids, diabetes, and a large factor. And radiation is one of the factors which can lead to cataract. Looking at the magnitude of the issue, according to the latest assessment which was reported by WHO, that cataract is responsible for 51% of the world blindness, which represents around 20 million people, and cataract surgery represents 12% of the US Medicare budget and 60% of all Medicare visual costs. So when it comes to the treatment, the spectacles cannot work because it is not an issue with refractive error, but of course it is one of the easily treatable conditions through surgery or through phacoemulsification. But there's nothing to match natural. Also there are risks of surgery which have been estimated. Examples are given here. So there are definitely risks associated with surgery, although it is a treatable condition. Going over to radiation and cataract, the radiation leads to dot opacities in the lens of the eye. And once these opacities have been obtained in the lens of the eye, there is a latent period, and through that latent period, it leads to the cataract. So these damaged epithelial cells, they undergo fibrogenesis and they accumulate at the posterior subcapsular part of the lens. This is the way one can represent the eye lens, and this is the posterior part, the posterior pole on the back of the eye, and there is a migration of these pseudoepithelial cells which ultimately tend to accumulate at the posterior pole. So that is what the understanding of cataract so far is. There's a question, is radiation-induced cataract different? And if so, how? In fact, this is a very pertinent question because hardly any effect of radiation are specific to radiation. If there is a person who dies because of work with radiation for 2 decades or so, and the family goes to the court, there is no way one can prove that the cancer in the person who died was because of the radiation. But somehow or fortunately, there is some degree of specificity in one effect, and that is the cataract. It has some degree of specificity, and that is because the cataract, the opacity, occurs in the posterior subcapsular part, not exclusively, but dominantly. So we tried to assess the score of the cataract to be able to give answer to the question which we have posed today, that is cataract a real risk? And I thought it will be good to have a feel of the scoring system, which is called Merriam-Webster score. There are other scoring systems also, but our ophthalmology scientist, he recommended that this is the best one for when it comes to scoring the radiation-related opacities. Of course, there is no unanimity so far, but that is what we chose. If there are no opacities either in the anterior part of the lens or in the posterior, then the score of 0 is given. If there are 4 dot opacities in the posterior part, then we assign a score of 0.5 as per the Merriam-Webster scoring system. And that score of 0.5 is pre-cataractous stage. And then if the number of dots are more than 4 and only located in posterior, then we assign a score of 1 as per the Merriam-Webster score. And this is an early onset situation. And score of 1.5 is when both eyes are involved, and that is where cataract in progress is the state. In fact, for having visual disability, one needs to have a score of 2 or more. So if one is having opacities in the level of 0.5, 1 or 1.5, there is a very little chance that the person will have visual disability, but one is carrying these opacities. And this clarification is essential because the results which are available as of now show that the people, interventionalists, had the scores of 0.5 to 1.5 and very few had the score of 2, and that is why where the visual disability may not be there, but there are lens opacities. But it does not mean that we did not come across cataracts, frank cataracts or surgical cataracts in our studies. There were few which we have reported in the paper. So this is, for example, of a person who had 22 years of work experience, and we found, and this was published in the paper mentioned there. Coming back to what I presented, that radiation-induced lens opacities have been observed to the extent of 1/3 to half of the operators. The question arises, how did we arrive at these figures? Let's go through the detail. It was in IAEA that we started IAEA cataract study, and that involved collaborators. Professor Vano from Spain, he is a medical physicist. Normal Kleiman from Columbia, US, he is ophthalmology expert. Dr. Minamoto is also ophthalmology expert. Then we had good cooperation with interventional cardiologists who helped us organize these studies, Dr. Ariel Duran and Dr. Sim. They were the one who organized in the cardiology conference, an interventional cardiology conference in Latin America and in Malaysia for participants in those. And then here we had our own medical physics colleagues who helped us. The studies were conducted in various parts of the world. As I mentioned, in cardiology conferences, we did the survey. So this provides a list of the places. And typically we had 4 workstations in which 4 ophthalmologists studied the eyes of the subjects. Every subject was viewed by 2, and if there was a significant difference, then the third expert, our ophthalmology expert, intervened and he settled the difference. And so all these studies were done after dilatation. In some cases, we had also the contrast sensitivity evaluation also. So based on the studies which have been published in good scientific journals, we found lens opacities of more than 0.5 in 38 to 53% of the operators. And that is where I took the rough figure of 1/3 to half of the main operators. And this was not only a epidemiological kind of a study, studying the prevalence, but we had controls also. That was the best part of the study. So cardiologists in that conference who had no history of participation in the interventional procedures, so they acted as control, and they were also age matched. So that way it provided us a very good opportunity to have comparison. And then we estimated the relative risk to the interventional staff as compared to the control. So that gave us a ratio of 2.6 to 5.7 times more likelihood among the interventionalists. The cumulative dose assessment, which was, we had rough method, we have described in the papers. I am not going through the detail of that in this talk today, was found to be in the range of 0.1 to 43 grays. So it's a very large scale of variation there. As I mentioned, we had age-matched controls, and we had statistical significance assessed by the established methods. The interesting finding was that among the nurses who stand on the foot end of the table where the interventional procedure is performed, we found 21 to 45% incidence of obesities, and with a relative risk of 2.2 to 5. This was a bit surprising to us because as physicists, most people will believe that inverse square law is supreme. If you are standing away from the source, you are protected by inverse square law. So that is what we felt, that the major risk lies to the interventionalist, the main operator or the system operator, whereas those who stand a bit away, there should not be that much risk. But finding these figures of lens opacities among this class of professionals, we looked back and we made the measurements, and then we realized that we ignore the fact of shielding. Main operators are invariably protected by shielding, whether it is a ceiling suspended screen or some cases there may be the eye lens, whereas there is hardly protection provided to the staff who is standing on the foot end like nurses. So that provides the reason for level of exposure and level of lens opacities. So this was a new finding, in fact, which we did not anticipate. We have published a large number, at least 5 or 6 papers in different journals. For example, in radiation protection dosimetry, there is one paper, another in cardiology, another in catheterization and cardiovascular intervention, another in radiation research, and other in Journal of Vascular and Interventional Radiology. And this last paper was chosen as outstanding clinical research paper, and Professor Vano, the first author, was awarded by the JVIR. I must mention that these studies of this kind are the first and most comprehensive studies conducted on the group of the people we are talking, that is the interventionalists. After that, now there is a lot of momentum and there are ongoing studies, but published studies were among ours the first one, and they were very comprehensive and scientifically well done. We had also in our studies in one conference included the Hammade system for contrast sensitivity. So this is a very, very preliminary data, and it is again first time that it has been reported in the paper in the JVIR that when it is a normal and in the aberrant with a score of very unfortunate score of 1.5 compared to 0, how there is slight change in the contrast sensitivity, but this needs to be further investigated. At the moment we cannot really confirm that this happens, and this will require further work, and this is only an initial finding. Well, there have been other publications which are available on the PubMed search. This is the paper, first one from Iran, and then the French multicentral study is ongoing. They have some initial finding, and the third paper, so again in cardiology. So prior to that, the first ever study which was actually started was in 2004 by Haskell and Vorgul, and that was a study done in RSNA in 2004, but that could not be published in the journals because there were no dose estimates and it was just a survey. But this did make a beginning in the direction of studying the lens opacities and cataract. And prior to that, in 1998, Professor Vano had published this paper in the British Journal of Radiology, and that was the very first report published among the interventionalists documenting cataract, not lens opacities, but cataract. Interaction with Professor Vano shows that it was not easy to publish the study because the hospital clearances and all, there are many issues involved in publishing something which can have an impact on the impression and detrimental and all that. So that also goes to show that there may be many things happening, but they are not being published. So that is always a situation which there is a possibility, but that was the first time in 1998 that this paper was published. So with that kind of a setup, there are of course some other studies which are for reference in today's talk, because they are not directly in the interventionalist, but among the Chernobyl liquidators. I remember in ICRP, it was in 2003, our chairman at that time, Fred Mettler, told us that Committee 1 of ICRP has been asked to check the complete literature for incidence and prevalence of cataract at doses below the threshold known at that time, because there were some indications from Chernobyl, then residents of contaminated building, astronauts, and radiological technologists reports. So there had A-bomb survivors. So there had been some indications that cataract was seen in the doses below the threshold doses known at that time. And there are other studies for reference which one can look at. So transition from lens opacities to cataract, at the moment it is unclear how frequently radiation cataract advances to the severe visual impairment, although the data from the A-bomb survivors by the Radiation Effects and Research Foundation have documented about 20 to 30% excess at 1 gray, and that could lead to the surgical level of cataract. So at the moment there is hardly much data available to talk confidently as to how many years it may take for lens opacities of different grade to reach cataract and what relationship it has with the dose. So this is an issue which still needs to be further investigated, but at least there is information that these opacities do progress to cataract, and this is the best information available as of now. I'm sure most of you are available about the latest change in dose limit introduced by the ICRP way back in April 2011, when ICRP had a task group on tissue reactions, and ICRP published its report 118, and they reduced the threshold for the eye from the level which I mentioned, 0.5 to 2.5, and occupational exposure dose limit was drastically reduced from 150 millisievert in a year to 20 millisievert, averaged over 5-year period. So this was a very significant decrease, and this decrease was not a sort of permanent solution. There were indications in ICRP that there could be a further decrease, or even the effect could be classified differently rather than deterministic or tissue reactions, all those things. So this was, ICRP never jumps into making conclusions quickly, so they they reviewed the whole situation, and at that time in 2011 they felt that a dose of threshold of 0.5 gray is reasonable, but there is the topic is remaining open for future reductions, and also for seeing that if this will go to the stochastic range. So going back to the slide which I presented in the beginning, has the threshold been reduced? The answer which we have seen is yes. Have there been published reports of cataract among those working in interventional suites? Again, the answer is yes. And have there been controlled studies among those working in interventional suites documenting cataracts or lens opacities? The answer is yes. So with that kind of the situation, is there a rare chance or a fair chance? It is for you to make conclusion out of it with the kind of figures which I have presented, which are like 1/3 to half of the people working as a primary operators with lens opacities being reported as compared to many other disease prevalences. This prevalence rate is fairly high. So of course this pertains to lens opacities rather than cataract. The relative risk among those in interventional suites, there has been new information on that. I thought I must bring that to your attention. Of course, the surveys done are mostly among interventional cardiologists, and some interventional radiologists, possibly some electrophysiologists are included, which they did not specify. They said, okay, cardiologist. There is no report at the moment among vascular surgeons, but the level of usage is similar among these categories. So again, like the case of nurses where this was surprise finding, so again, there is a scope for surprise among the orthopedic surgeon, urologist, endoscopist. And it is here I wish to present to you the latest work which has been published in 2016, again by Professor Vano's group. And this is the slide which shows the patient dose per procedure as a median value among the interventional cardiology, neuroradiology, interventional radiology, vascular surgeon, and urology. So one will assume that the urologist have encounter to the lowest radiation dose as compared to others presented in this. But when one sees the eye lens dose to the staff, it was reported in that paper the urologist had the highest, and then the vascular surgeon. So it takes us back to the same issue which was regarding nurses. That is the known use of the protective devices. So urologists in their procedures have very little chance of use of protective devices because of the ceiling suspended screen, which is easily available in case of cardiologists, but also in urological procedures and in the machines, the angio machines which they use. So with that, this is going to be the attention of future where these groups need to be investigated further. So I think there is a fair evidence, and with that we need to say that, do not say that we did not warn you, and one needs to be really careful. So assuming that now we are reaching a conclusion, if the risk is real, the question arises what to do, although today's topic is not supposed to be totally focused or significantly focused on that. But one point I need to bring home that it can be prevented or avoided almost fully, almost 100% preventable. So this is one of the very, very rare situations where one can confidently take steps which are known to really help that. Some quite reasonable information is available on the ARPO website under the category of radiation and cataract. And if you put in the Google radiation and cataract, and you on the first page, you are led to the ARPO IAEA page, ARPO IAEA pages, which give you the information. And in addition, also on the ARPO website, there are these posters available which help to indicate what actions need to be taken to avoid or prevent cataract. It's a satisfying situation to see that some of the professional bodies like, say the Cardiovascular and Interventional Radiological Society of Europe has a pavilion which has been radiation protection pavilion, which was done in the annual conference they have, giving a very alarming kind of image like this. And in the US also, the Society of Interventional Radiology has been showing interest, but there's a need for much more to be done by various societies because the workload of interventional fluoroscopy procedures is quite large and there is a significant increase annually. So there is a need for action by other professional bodies of the electrophysiologists, vascular surgeons, orthopedic surgeons, urologists, and other healthcare workers. So the professional societies of these subjects should come forward. So to recap, what I talked about is 2 decades ago, it was not a big issue. Changes which have occurred during the last 2 decades in terms of the actual data which has accrued and the recommendations by the authorities, cataract versus the lens opacities, grading of opacities, controlled studies, and drastic reduction in dose limit by ICRP, which has been accepted by IAEA, incorporated into the International Basic Safety Standards, and most other organizations have also accepted this, and those some others which are going through the process of acceptance. Ongoing actions and future actions needed, I briefly touched upon that. Thank you. Let me go to the questions now. Let me see.
Yes, thank you, Madam. You have several questions already assigned. You can see my Q&A box.
Is there a electronic copy of the presentation that you could email to me? I am sure Zenia has already announced in the beginning that this presentation will be available on the RPOP website. So for anyone to see at any time, as many times, and I believe there will be possibility to download. If not down, one can always get a copy from me or from IAEA. Then, Zenia has already replied to that.
You can go down. There are 4 or 5 questions assigned to you in your Q&A box. The first is, could you please explain in more detail the fact that the main operator is better protected by protective shielding than the staff standing further away? That is not very clear for me.
Yes, this is a fact that these days, assuming that main operators are using the ceiling suspended screen, where the compliance rate is much, much better now. Whenever I used to go to any country some 15 years ago, the ceiling suspended screen used to be staying in corner, gathering dust. I don't see that happening any time now. It's very rare to find that situation. So with that, the protection provided by ceiling suspended screen is very, very effective. And which is not the case for the others who are on the foot end or on the other side, unless the other staff is using the lead glass eye wear, then the protection is not adequate. So the use of lead glass eye wear for people who are inside the room and who have not the protection by the ceiling suspended screen is essential to be used lead glass eye wear.
The second question is, how did you determine the dust to the length of the eye of the operator in your study?
Well, that's a very interesting and very good question. The short answer is that it was a very rough estimate based on the workload. All these details have been published in the paper, in the papers which I mentioned, but to give an answer briefly, that we interviewed each and every person before testing the eyes. Every person had to fill up a long form where he or she had to provide the workload, the number of years working, types of procedures performed, the usage of the ceiling suspended screen in terms of more than 70-80%, 50 to 70%, things like that. So it was all subjective feeling given by that. Based on that, we had chosen a value of the dose to the lens of the eye when it is unprotected, and then we applied corrections. So this was like a reconstructing situation. Scientifically, initially we felt that this may be not acceptable by any journal to use a method like this, but since there is nothing else better available, so this was accepted by journals also as the method. So we cannot say that this provides the accurate estimation of dose, because there is it's very gross with possibilities of large errors, but there is nothing better than that which is available or which was available. At least now there are some semiconductor small devices with which one can assess better. But that was the best possible available at that time.
Yes, there is a connected question. In your studies at the conferences, how did you get occupational doses? Interventional radiology doctors for not wearing dosimeters routinely large underestimate if go by dosimeters if you calculated error. Can you repeat it question?
We get the dosimeter readings because they were not available in more than 95% of the cases. So the dosimeter readings in any way are unreliable because people do not use them properly, and we had done a survey again on behalf of IAEA. We had written to the radiation protection authorities, we had written to the cardiology societies through the project called ECMER to check, and the results were very frustrating. So that path we did not take. So we did not estimate the eyeless dose using the dosimeter badge value. These were all the dose values were based on the assessments made on the workload and other factors which I just mentioned.
Thank you. There is a question, what do infants with hemangioma treatment have to do with cataract formation?
Sorry, say again.
Can you see this question? What do infants with hemangioma treatment have to do with cataract formation?
Okay. That's why I said these are not related to this. So that's why the title of that slide also showed. But there is evidence from some of the radiotherapy patients and like astronauts also and Chernobyl survivors. So these are all other areas where there has been information. So that's why I mentioned they are not directly on interventionalists, but there is sporting information available, which also tends to show that cataracts were observed at levels below the threshold known at that time.
Okay. There is a question, in what region were occupational dose limits to the eye lowered? In the US, 0.15 sievert is a standard limit. What are the IAEA recommendations?
Well, the US is, the NCRP committee is going through that and they are in the process. So their report is expected anytime for NCRP. So this has been an ongoing step of review and decision making. So in fact, it was expected in 2015, but I am told that anytime early this year it should be coming. So I don't know whether the same values are going to be adopted like 20 millisievert rather than the 50 which is currently they have, or 150 which they so. But the review process is ongoing, and those limits will be provided by NCRP. That's what I know.
Are opacities irreversible? There is a question also.
There is hardly evidence to say so, at least from the animal studies, which there are lots and lots of animal studies are being done in Dr. Kleiman's lab and elsewhere. And the data from there does not really clearly indicate so. So, to the best of my knowledge, it is not so that they are reversible. I may be wrong, but I am not the real expert on that to say, but that is what my knowledge goes for as far as it goes.
Okay, where are the radiation sources in the interventional suites coming from?
Well, from the X-ray tube, scattered radiation, from patient, from any material. That's it.
Yes, and the main source is scattered radiation from the patient. Okay, is there a difference between right and left eye?
Yes, invariably the person will have more chance in the left eye, the way person stands, at least in cardiological procedure. So unless the person unless the geometry is such that the right side is getting more, but invariably the geometry of day-to-day work is that the person stands for doing catheterization procedures with left side facing towards the X-ray tube, and the intensity of radiation falling on left side is more than the right side.
Thank you. Your only slide on estimating occupational dose is totally contrary to the observed fact urologists have greater dose than cardiologists.
High dose, not the dose levels used by urologists are less. That was depicted from a patient dose. But that is why initially the initial slide I presented is based on the belief, but the data is contrary. So that is why I said that there are situations like in nurses also we believe that they should not have much chance of obesities, but then it was a learning experience. So similarly, the finding with urologists is a learning experience. Obviously, it is not what we anticipated.
Thank you. Could you have any information about cath lab system dose comparison between different vendors, Siemens, Philips, GE, Toshiba?
Well, that is not the topic of this seminar today. We hopefully will have other seminars dealing with those things, but there are studies to that effect.
And how well does the color badge indicate the dose to the unshielded?
Again, many of these questions are on dosimetry. That's why in the very first slide I mentioned this is not a presentation on the dose assessment. We will have another presentation on that, but briefly, not to say that there is no answer or I don't want to give an answer. Briefly, yes, roughly it correlates well, at least with the current level of acceptance of initially whenever you start with any estimation, you are fine with 10% of plus minus, and then you want to make it better. So at the moment when there is no other mean available, collar level is good enough. So at least something is better than nothing. That tomorrow when we have these small semiconductor devices which can easily be placed on near the eye, so obviously then the collar level may not be acceptable at that time or at some other methods, but at the moment collar level badge is good enough.
There is an interesting question. What is your opinion about the influence of the usage of real-time dosimeters regarding lowering the dose?
The short answer is yes, it is useful.
Yes, because this is one of the important aspects. So regardless of operator dose, you have determined operators of interventional fluoro have a greater incidence of cataract, regardless of operator dose.
So, sorry, repeat this question again to get it better.
Regardless of the dose to the operator, you have determined operators of interventional fluoro have a greater incidence of cataract.
On one side it is regardless, on the other side the question is not so clear, but obviously the operators have the greater, because the dose is high to them as compared to the non-operators. So if I understand the question right, so that is the answer, that despite the usage of protective screens, still the radiation dose estimated in these cases is high. So it's all a question of the final dose which reaches the eyelids.
There is a question: which nation have accepted new limit for lens, for eye lens? The new ICRP occupational dose limit.
I think most of the countries, either they have accepted or they are in process of accepting. So nobody is objecting to that.
And this is in the new international BSS already, and this is in the new, for example, in Europe, this is in the new European directive.
Yeah, so there's nothing against. It's process part takes something 2 years to 10 years. So some countries take longer time. So this has been since the last 30 years. Whenever new recommendations come, there's a long period in many countries. So it is a process part. It does not mean that the countries are not accepting or they have something against.
Is there a greater risk of higher lens dose with harder beam conditions when added copper filtration is in place?
Obviously, short answer will be yes, but one should think of the intensity also going down. So it may not be clear-cut situation. So if the intensity has gone down significantly, and then those may not be high, but otherwise there is a possibility. So one needs to really measure and see. I'm just thinking of what could be possible.
There have been some papers that not cortical opacities can be radiation-induced. What typically occurs first, posterior or cortical opacities?
Well, yes, as I said, it is not exclusively to the posterior subcapsular region, but dominantly. So the main message which one needs to get is to have a comprehensive examination by ophthalmologists. Sometime the ophthalmologist may not be looking at the posterior subcapsular region because their main attention may be going to the anterior and nuclear and cortical regions, leaving the backside. So whenever we had to train or orient the ophthalmologist for this study, so this was one of the main factors which we had to tell that the focus is there, but obviously one has to see all the regions of the eye, and there are situations where the opacities may be in the regions other than the posterior subcapsular region. And in fact, even the control people, when they had this less than 10% in some papers and a little more also posterior subcapsular opacity. So it means the posterior subcapsular opacities can also occur beside radiation because these were control people. So although we had been very, very careful in excluding patients with steroids, diabetes and connective diseases which can lead to posterior subcapsular, so these are the things which one needs to go through in detail and not look only at one region and that's it.
Okay, more questions are coming. There is an interesting question. I fully understand safety should very important. Cataract is largely age dependent and easily treatable. Why do we need to worry about cataract as an issue?
I think I had already answered this. First thing is that the cataract by age dependence is a separate thing, and this is a separate thing. So if easily treated also, I had mentioned the risks of treatments. There was one slide fully on that. What are the risks on because of the surgery? And there is nothing like natural. You may have hip transplant, knee transplant, denture, but you miss the natural, your natural thing is natural. And secondly, lastly, there is no better way to manage life than preventing the effects. So as a philosophy of life. So I think all these points pull up.
Yes, it's preventable. Should there be a baseline assessment and annual eye lens assessment by an ophthalmologist for all staff working in interventional radiology, etc.? What is your opinion?
I will first like that those monitoring systems be there in place. And secondly, the prevention, the preventive aspects should be. So rather first preventive aspects, secondly the monitoring, and third is the health assessment. So if you see that the doses are going higher, then assessment comes. If you see that the doses are not, they are small, so then assessment may not be needed. But that is something which is more of a scientific reply. From the regulatory perspectives, IAEA has worked on it to see, and I don't know what was the final outcome from the ILO people, because the ILO is the one who guides IAEA in the standards on if there should be requirement for monitoring and health screening. So in many cases, ILO has felt that whenever it comes to radiation effect, the normal health screening should be adequate rather than specific. So in this case, I don't remember what was that. There was, Lenia, you will need to look at the tech talk. There is a tech talk which was brought out by IAEA on this issue, and one needs to look at that. What was the ultimate decision on that aspect? So I think I will prefer to see that before making any comment on that.
Thank you, Madam. There is one more question. It surprises me that such a high dose to the eye lens can be accumulated without exceeding the whole body dose limit. Can you comment on the explanation?
Well, the lead apron worn by staff takes care of the whole body dose, whereas if you do not have the ceiling suspended screen, then or no lead glass IVR, within 1 month you can accumulate high dose. What to talk of year? So this is no surprise. It is easy to document.
Yes, a question regarding the threshold. Is there any research done regarding the threshold on the dose below which there is no effect to the eyes?
Well, that is something which is a future topic being looked at. As I mentioned, that the review done by Narishi, Roy Shore, and there are a lot of reviews they have done, and where they found the threshold is between 0 and 0.8 gray, and then ICRP settled on to half, somewhere in between 0.5. So there is research going on that issue. At the moment, whatever was best, ICRP decided, but there is, yes, so there may be, this is a topic on which change can be expected in the coming years.
Okay, we are getting more questions, although we are close to the finishing. Not sure if you saw my question. What is your thought on time between exposure and cataract being detectable? The time period between.
That was a surprise to us, so it's very difficult to answer this question. I remember in Thailand study when I was there, so there was young person with 1.5 year working experience who had the 1.5 degree of the Merriam-Webster score, and we were surprised. Similarly, in Latin American, when Dr. Vano and others, so they also saw, so there were sporadic cases of less working time and having very high degree of opacity, whereas others who had 20 years of work and very little opacity. So at the moment, the data is inadequate to say anything on that. And also the data is not adequate to say that you cannot have opacity with a few years of work. So at the moment, it's not possible to give any confirmed situation on that.
Yes, there is a question regarding the dose limit to lens for radiation worker having artificial lens already operated for cataract. Can you answer this?
I'm not aware of the artificial lens getting cataract, so this is the natural lens is a very, very complicated structure, although it's just called lens. But if one sees the details, I was yesterday thinking of adding a slide on that. It's a very complex structure. So whereas the artificial lens is a simple structure, so I will prefer an expert on artificial lens to comment more specifically, but my own understanding is that natural lens is different and artificial lens may not have the opacities generated. That will be my understanding.
Thank you. We have a few more questions regarding the dosimetry. I think we'll have a separate topic on eye lens dosimetry in future. So probably the last question, in your opinion, which one will be the minimal protection necessary for avoid lens injuries in occupational protection?
Yes, this is the best part, that one can use the minimum protection. When it comes to minimum, I think the lead glass eye wear with adequate 0.7, I think, millimeter is good enough with the sideways covered on the sideways. So that is the minimum for the eye. But for main operator, both the screen and so for others, lead glass eye wear, and for the main operator, both should be counted as minimum, the screen as well as the lead glass eye wear.
Good. Thank you, Madan. I think we had a lot of great questions and an excellent discussion. I thank Professor Rehani for his excellent contribution and thank to all attendees for joining us for this first webinar. This webinar will be archived and the link will be available from the webinar page of the RPOP website. You can see on the screen the RPOP webpage. You can go to the training page and there is free webinars subpage, and there you can find the list of the already done webinars and forthcoming webinars. And from the link there connected to the topic, you can view the broadcast at any time. You are also welcome to submit your proposals for next topics in our webinar series, sending email to our email address. Thank you for your participation and have a wonderful day or night. You can now disconnect.
Thank you.